So I think we can start this webinar. So first, I would like to introduce myself. My name is Sara. I'm coordinator on health systems governance, policies and aid effectiveness in the World Health Organization in Geneva. It is really an honor to have you all on board today for this second webinar of our series on governance frameworks and missing links. Just to remind you, we had the first webinar on the 24th of November. It was co-organized with Collectivity and with Bruno Masons. And it was about troubles with the building blocks, with a fantastic presentation by Sara Bimbola and a very intense discussion we had. This one is then the second one, and it is about governance in practice. It is co-organized and co-hosted with the Health System Governance Collaborative, or recently created Global Networks on Health System Governance, as well as by SHAPES. SHAPES is a technical working group on health systems global and was founded in 2011. Before starting, I would like to inform you all that this webinar is recorded and that the slides and the recording will be shared online after the webinar. I would like also to thank, because I may forget at the end of the webinar, the main organizers, and in particularly in SHAPES, Kerry Scott and Stephanie Top, in Apt Associates, our colleague Jennifer Leopold, and in WHO, Benjamin Rufi, Mariam Bigdeli, and Godlieve Van Heteren, who have prepared technically this webinar. We have also, of course, the fantastic support of our technical colleagues in Geneva, who I would like to thank in advance for this successful webinar. So we are together to discuss today governance frameworks in practice, and we have two presenters with us. We have Bob Fryatt from Apt Associates, who is the director of the USAID Health Financing and Governance Project. And in addition to his prestigious academic background, Bob has, of course, a long-standing experience of health systems in low, middle, and high-income countries, and is certainly the person to do the first presentation today. Second, we have with us Sara Bennett. Sara is professor in Johns Hopkins, and she is currently the director of the Doctors in Public Health Programs in the Health Systems Program at the Bloomberg School of Public Health. Sara is also the CEO of the Future Health System Consortium, and she has also a vast experience of health system projects in collaboration with the World Bank, the FID, USAID, UNICEF, and many other partners. How are we going to proceed with this webinar? First, Bob will start with a short presentation on the key points developed in the recent but already famous paper on health sector governance, Should We Be Investing More, that he has co-authored with Sara, as well as with Anya Sukat, who is my director, by the way. And just after Bob, Sara will follow up on why it is necessary to simplify governance in order to amplify, and she will help us to open the debates around governance and the obstacles we are currently facing to improve health sector governance. After that, we'll have questions and answers and a debate. And I already invite you, all participants, to raise your hands electronically, or to send us a chat message or questions during the webinar. And my colleague Benjamin will help us in gathering all these questions and transmitting to everybody. So I stop here, and I would like to give the floor to Bob for the first presentation. Bob will then explain to us why we need to invest more in governance. Bob, you have the floor.
So good morning and good afternoon, everybody, and thank you for that introduction. So yes, I'm going to go through some issues around making governance frameworks fit for practice, and we've entitled this Simplifying in Order to Amplify. So I'm just trying to get my screen to work. We all know that health sector governance brings better health. That's why we're on this call today. And we know that there's good evidence behind this. Spending, we know, is twice as effective in improving under-5 mortality and increasing life expectancy when there's higher quality of governance using the World Bank governance measures. We know that the impact of international development assistance is dependent on the quality of institutions and of policies, the key aspects of governance. We know that strong public financial management reduces corruption and improves the likelihood that increased public health spending, where that can happen, improves health outcomes. We also know that governance of public health agencies, such as those responding to public health emergencies, a key factor in their performance is the quality of governance. And at the health service provider level, we know that where service providers are more accountable to their local communities, they actually improve the health outcomes of those communities. There's compelling evidence that now exists and how governance interventions lead to sustained, improved health. 4 recent reports that have just come out from the Health Finance Governance Project with USAID and WHO on marshalling the evidence for health governance, and it shows that there's compelling evidence in a number of areas where interventions improve health. Yet many still question whether investments in governance of the health sector can reap the benefit in terms of improved service coverage and outcomes. And we're posing the question today, why is that? And there are a number of reasons, and Sara later on will go over this in more detail. But one of the reasons that we are proposing is that there's not a good understanding, and we're not very good at communicating this to the broader public health community. One paper that came out in 2014, this is a paper commissioned by WHO in Europe, looked at definitions and dimensions in governance, and they commented on that the governance function is still, to many public health practitioners and to policymakers and managers, it's still an elusive concept. They commented on the conceptual chaos across many papers and academic papers. And many people still seeing this as being quite ambiguous. And I'm particularly talking about the international public health community and investors in public health. And after doing a very long review of the dozens of papers on definitions and frameworks and governance and health, they concluded that we in the sort of international public health community need to resolve these conceptual confusions, and that will help transform the governance function and investments in governance. So with that in mind, I worked with Sara and in John Hopkins and Agnes in WHO to try and simplify what we mean by health sector governance with the aim of improving our understanding and how we can strengthen it and also amplify the investments in it in the health sector governance. So we are proposing, and this is what we're trying to do here, and of course this is one attempt amongst many to simplify and communicate better about what we mean. To try and simplify the concept of health sector governance, we propose that it has 3 elements that can be applied at 3 levels and can be assessed using 3 different types of measures. The 3 elements, first of all. We're proposing that governance entails transferring decision-making responsibility from individuals to governing entities, and that implementation is by one or more institutions, and that there needs to be accountability mechanisms that monitor and assure that the progress is being made on the decisions made, engaging the governing entities and the institutions, and also those on whose behalf they are acting. Accountability, of course, has both short and long routes. The short route is between service providers and those being accountable to local communities and to clients. For example, primary healthcare services to local services or specialist hospitals to local communities. The long route is through, for example, parliaments and the number of institutions that improve the population's health, such as ministries of health and centres for disease control. There are many other examples. Next, about the three levels where these governance elements can be applied. They can be applied to one of three levels. At the broader governance level, beyond the health sector, where there are examples, rule of law, bringing peace and security, all have an impact on health. They can be applied around public policies, and these public policies may be around, in the health sector, around areas such as public financial management, or around public health law, which is in law, for example, clean water or clean air. And they can be applied to organizations, such as ministries of health or hospitals and providers, all of which need a governing entity, some sort of institutional mechanism for implementation of decisions, and an accountability mechanism. And lastly, we think all of this can be assessed, all these elements and levels, their governance effectiveness can be assessed using a simple structure, process, and outcome measures. And we're talking here mainly about practitioners, not about research. So when it comes to assessing governance function, it's possible to do this using existing information. And we can ask, for example, on structures, are governing entities, their implementing institutions, and accountability mechanisms defined, in place, and functional? Secondly, on process, are the decisions being made? Are implementation arrangements underway? And on outcome, whether accountability mechanisms are reporting on the desired improvements in performance and on health outcome. So these three elements of health sector governance can be applied at three levels and can be assessed using three measures. I'll now give you three examples, one from each level, and then finish with three key messages. My first example, there's compelling evidence that gender-responsive budgeting works. Now for this, and this is beyond just the health sector, usually the governing entity is the Ministry of Finance. They make the decisions and set the rules. Implementing institutions align ministries such as the Ministry of Health and the health sector, but also this could be applied to education and other areas. And in the health sector, the other institutions around purchasing bodies, those are actually responsible for putting together the budgets and executing them. And the accountability mechanism is through gender-specific performance indicators. There's very good evidence in many situations that gender-responsive budgeting works. Second example is around public policy. And the one we've chosen here is task shifting. Again, compelling evidence that this can work. Usually the governing entity is the Ministry of Health. The implementing institutions are pre-service and in-service training institutions and accreditation bodies, professional accreditation bodies, but also service providers. And monitoring, the accountability mechanism for this usually is in checking to see, monitoring the service quality and coverage, which is expected to expand under this policy. And lastly, an example from organization, in this case, service providers, health service providers, around social accountability. Here, the governing entity may be the oversight committee that oversees a facility or a service. The institutions involved are providers and usually community-based user groups. Institutions can be informal as well as formal. And the accountability mechanisms are usually is some sort of citizen scorecard and the transparent use of performance data, whether it be for coverage or for financial audits. Again, an area where, if done properly, there's compelling evidence of effectiveness. So finally, I've got three key messages around health sector governance to the international public health community. I think we need to stop talking about frameworks and definitions. We need to start investing in interventions where there's compelling evidence of their impact on health. And by doing that, I think we will expand essential health services to those that need them. Thanks very much.
Thank you. Thank you very much, Bob. Brilliant. Thank you. We have well understood that that first, governance is key to achieve universal health coverage. It's a critical foundation needed for this. And we have well understood also your messages. We need to stop talking. We need to invest and invest much more into governance. And with all that, we need to increase coverage. That is certainly our UHC SDG 3.8 objective. Thank you so much. And I would like now to give the floor to Sara, who will explain to us in practice how we can simplify governance to amplify. Sara, please, you have the floor.
Thank you very much, Gerard, and thank you, Bob. I'd really wanted to make just a few remarks to help move us into a discussion. And I think that Bob has laid out nicely some of the ideas in the paper and also sort of some of the bare bones of the framework that the paper presents. But really the starting point for wanting to write something and write something short and punchy about governance was the sense that in the other dimensions of health systems, there has been really substantial progress if we think about health financing, human resources for health, service delivery. There's been a lot of work and quite a lot of experimentation. And I think our collective sense was that the governance agenda, the health systems governance agenda, had progressed less than some of the other aspects of health systems. So I think we had wanted to talk through, why that was the case. I'm having difficulty moving this. Oh, here we go. So I think, too frequently when we're gathered together to talk about health systems, governance is essentially the elephant in the room, the thing that everyone is aware of, and yet we don't necessarily talk as directly about as may be needed. And working with students at Johns Hopkins, and I teach a health systems class, we go through different functions of the health system, and when it comes to governance, I think there's often a sort of a clicking in people's head that this underlies so many of the different aspects of health systems, and yet perhaps is not directly discussed. And instead, we sit around the table talking maybe about performance-based payment for providers, or about how we can generate, how we can move towards universal health coverage. And yet we're thinking, well, our financial management system is too weak to do that. Or maybe we have concerns about how effective regulation can be, and we're aware of issues of corruption and graft within the regulatory agencies, or indeed within amongst other stakeholders in the health system. Or sometimes we're concerned about health sector accountability and the fact that healthcare providers or health sector managers are not held accountable, and accordingly it's really difficult to move services along. So I think sort of the starting point for thinking about this paper was really, well, how do we help to generate a more open conversation about governance and recognize that it's threaded through so much of what we do and try to work on in health systems. So I thought it would be worthwhile spending just a minute or two trying to unpack why we don't more frequently act upon governance concerns, but maybe keep them silent. And I think that Bob has already talked about one of them, and one that the paper sought to address in some form, which is that governance is often perceived as messy, diffuse, and conceptually difficult. Bob talked quite a lot about evidence, and I think that this is a sort of glass half empty, half full, in the sense that I think that there are some interventions around governance and some aspects of governance where we really do have strong evidence to support action in this area. But I think one of the really difficult things is that we still lack information sometimes about how do we take those interventions that appear to be effective in a particular context and how do we implement them in different contexts? What does that implementation process look like? And how do we scale up some of these apparently effective interventions? I mean, I think I go back to the paper by Bjorkman and Svensson, which was looking at community-based monitoring in Uganda, and showed that that particular intervention in that particular context had a really substantial effect on childhood mortality. But then when you think, well, how feasible is it to scale up that intervention across Uganda? How might the intervention need to be adapted to different contexts? And how might we need to tweak the implementation process? And I think that that's really where the challenges lie. And if you look at any of the systematic reviews that have been done in this space, they find at scale, governance interventions seem to have a lot more mixed effects than when we're doing them in sort of randomized cluster control trials. So I think that there still is a need for further evidence, but it's not about can these interventions be effective, it's about how do we adapt them to context and how do we scale. And I think that's really important because in the health systems environment, there is a tendency to talk about governance interventions. How can we come along and intervene, make a sort of a sharp, structured intervention into the health system? And perhaps we don't sufficiently frequently recognize that when we are intervening, we're intervening in what is already a very complex social fabric with existing patterns of accountabilities and power relations. And so that intervention may look different according to where we place it. And I think Shay Abembola's work in this regard, talking about governance hardware and governance software, is very relevant because it's particularly the software elements of governance, the relationships, the issues of trust that can differ and that we don't always read very well. And so our intervention, it's true across all sorts of health systems interventions that, you know, we're not intervening on a tabula rasa or a blank slate, but I think it's particularly important for governance that we understand the nuances of the context that we're intervening in. And finally, and this is important, I think, is that until now, I think there has really been insufficient discussion about the political economy of governance. So in my experience, conversations about governance may frequently be initiated by civil society organizations who are frustrated about the lack of attention to governance. But it's much rarer that a policymaker, a national policymaker in a country will recognize and speak openly about the kind of governance challenges that they face and ask for support to try and strengthen accountabilities within that system. And I think that this also speaks to the issue of sustaining interventions around governance. How, you know, stronger governance can be very uncomfortable for some of the key stakeholders within a health system. It brings them to account in more difficult and more open and more transparent ways, which is not always appreciated. So I think we need to think more about the political economy around governance and how we manage that. So finally, I wanted to talk a little bit about, well, how best do we proceed with this agenda? I don't know if there is a consensus amongst those on the line, but I guess my view would be that governance is critical to so much of what we do in the health systems environment, or you know, to strengthen health systems, but we don't talk about it enough, and we don't consciously address governance enough. So given the challenges that I've just identified, how can we proceed in this space? And the paper that I wrote with Bob and Agnes provides some of these suggestions and some other ones, but I guess I've highlighted the ones which seem most important and most critical to me. But I would welcome the views of other discussants and panelists. So firstly, I think we need to be both strategic and realistic in terms of how we intervene in terms of governance. I think we need to think more about doable and discrete interventions. What are good starting points for addressing governance? And in particular, what are the entry points that may lead to sustained improvements in governance? So I guess what I'm thinking here, the sort of underlying thinking, is that sometimes we intervene in a way that is controversial, that may disrupt existing systems. And that may be absolutely necessary, but if we're not careful, it can also close down the space. We can get reactions very quickly that simply prevent, powerful actors may intervene to stop further progression on the governance agenda. And this is coming back to the question of political economy around governance. So I think we need to think carefully about, what are the entry points that may gain support amongst key stakeholders and may lead to sustained improvements in governance, rather than being a flash in the pan, something that occurs, is effective, but gets closed down shortly afterwards. I also think we need to think more and analyze more about disruptive innovations and experiment with them. I agree with Bob's, one of Bob's sort of final comments, that we need to do more and get out there and be active and see what the consequences are. But I'm interested in particular in disruptive innovations. And I'll give just one example coming from mHealth, or sort of more broadly, how we can use information and communication technologies within health systems. And I think ICTs can be particularly powerful because they can shift power dynamics by making information more publicly available to different groups. So for example, if you think about call-in centers, or ways where citizens can perhaps bypass frontline healthcare providers to get other sources of advice, that immediately shifts the power dynamics between the different stakeholders within the health system. I think the internet can also be really important in terms of providing protection to the anonymity of whistleblowers. So there's a lot of interest, I think, right now in how can we use the internet to get clients within the health system to report incidences of abuse or bad behavior. That brings an awful lot of questions with it, but I think that its disruptive power is worth exploring further. Thirdly, I think it would be good to talk about, and to talk again strategically, all of these require really strategic thinking, about how we can build coalitions for governance reform. Jonathan Fox, as many of you will be aware, talks about the importance of combining both voice and teeth. And I think often we have incidences of voice where we try to give citizens the ability to raise their voice, to articulate concerns about the health system. But if we don't also match that voice with teeth in terms of having more powerful stakeholders within the health system be able to support actions to address the voice, to address the concerns of citizens, and then I think that there's a possibility that citizens become disillusioned and disempowered. So I think we need to think about how we can build coalitions. Where do we get the support from more powerful actors within the health system to really build coalitions for governance reform and to support citizen voice? And finally, although there is clearly very strong evidence about the potential effectiveness of some of these interventions, I think that we need to continue to document what works and to learn from experience. Because I think one of the biggest challenges about working in this space, and I suspect my comments so far have been quite clear on this point, is that although we know things have the potential to be effective, we're not always very good at adapting them to particular contexts and taking them to scale. So those in a nutshell are my thoughts on this, and about why governance has been neglected and how we may wish to go about amplifying governance on the health systems agenda. But I very much look forward to hearing everyone else's ideas and thoughts. Thank you, Gerard.
Thank you very much, Sara. Really crystal clear, and thank you to remind us that governance is the elephant in the room, and we have a lot of questions. I think you were also very clear in asking these questions and with your conclusions on the need to be strategic and realistic, on the fact that it's worth exploring disruptive innovations, building coalitions for governance reform, and documenting also very importantly what works well and maybe less well, and learn from these experiences. This is something that certainly you and Bob have worked in collaboration with other colleagues on this exercise in marshalling evidence that is for health system governance, it is critically important. Direct reaction to this, and probably from the WHO perspective, we cannot agree more, and we do think that's really very timely. We need to embark into an ambitious, actionable governance agenda. We need to move things forward. We have been able in the past to maybe focus a bit more on measuring certainly accountability, measuring transparency and responsiveness. We probably need now to focus a bit more on actions, on which actions work in terms of participation, in terms of bringing the citizens and capturing the voice of the citizens, in terms of the architecture of the organizations and the way the institutions are functioning together, the relationships between the different groups. And it's very well explained in your paper, Bob and Sara and Agnes, that we have a clear triangle between the state, the citizens, and the service providers, and it's very important to understand what and how it works at the level of each of these groups and between these groups. Information is critically important and very needed to improve transparency, and there again we can certainly use more the innovations, and as you well mentioned, the MLs and the web, and we also certainly need to be very clear on what we need to do in terms of software, but also what we need to do in terms of hardware. In some countries, maybe some institutions need to be built to improve governance, while in others, the institutions need to be strengthened to improve the overall performance of the system. But I will stop there, and I would like to, we have asked to three discussants to provide a direct comments on the presentation. I would like to start with Mr. Walter Flores from the Center of the Study of Equity and Governance in Health Systems. Walter, are you with us? Could you please provide your views on the presentations and on health system governance?
Thank you. Thank you. Okay, because it's very brief, the time that I have, I'm going to go straight into the issues. First, I do not think that the issue or the problem with governance is because frameworks are too complex or because of the concepts are too complex. To me, that's not the problem. The problem why governance has not been taken seriously is because it is an issue of power. It's a tackling power. And part of the issue, for instance, which caught my attention also from both presentations, is that they are using the World Bank more than 10 years ago framework of the short and the long route of accountability. And that caught my attention because even the bank themselves, people at the World Bank, they criticized that they were naive when they developed that framework. Because if you see, that framework is totally blind about power. And they say that it is not really that kind of relation because everything within public institutions is mediated by power. And as a response to that very weak framework, they themselves say that that's why they published the 2017 report, the one of this year about governance and the law. And within that report, if I don't know how many of you had the chance to see it, it's a total different framework, which is more about power. Even the definition that they have in that report, they say that governance is about about decision making, but that is under a set of formal and informal rules that shape power, but also is being shaped by power, those decisions. So in summary, again, I don't think it is because the frameworks are complex, it's because that tackling governance has to do with tackling power. that's one. My second comment has to do with the situation that when we talk about governance, we have to be aware that this is about the architecture of public institutions. And in any public institution, we are concerned about improving governance because of three main goals that we're trying to achieve. The first one is that there is transparency, there is accountability, and also there is participation. And participation as a way of direct check and balance of public institutions. So if we have these three main goals in mind, then we can see that one of the main problems in the architecture of ministries of health, in my view, it is because they are very much influenced by the design and the idea of self-regulation. The Ministry of Health is very much based on what happened with the medical self-regulation. So almost everything with the Ministry of Health, it has very weak governance and accountability because of the self-regulation. And other public institutions, they are different. For instance, the education sector in many countries, for instance, if you go to the Ministry of Health, you will see that doctors that provide services, they also control the funding of the services. So one of very concrete practice of public institutions to bring governance is to separate the handling of the resources, the decision-making of the resources, with the provision of the services. But so you will see that the Ministry of Health, in most cases, is not separated. But if you see the Ministry of Education, in many countries, the teachers do not control the funding of the schools. It's the Parents Association. So the Parents Association controls the funding of the schools. They control many of the activities. So within the same country, you can find that some public institutions, such as the Ministry of Education, are better in terms of how they implement these three goals that I mentioned: transparency and accountability and participation. So within ministries of health, because they have this problem, as I say, of self-regulation, almost wherever you see with the Ministry of Health, there is a risk of conflict of interest. Almost everywhere you see, from the very local services to the very top of the Ministry of Health. And that is the main issue that creates problems with the ministries of health. For instance, one common problem in many countries is that the Ministry of Health do not work as a unit, but you will have that different directorates or subunits within the Ministry of Health are either have more capacities or either have the decision-making of funding directly, either because they receive funding directly from donors, vertical donors, or for other purpose, but they do not even apply and follow the regulation from the central level, for instance. And also, another very common problem is that you will see that some units within the Ministry of Health, they engage with vested interest organizations. For instance, there are some units that they collaborate and they engage very much with the private sector, especially with carbonated drinks, because they help them to deliver medical supplies to the rural facilities in the same trucks where they take the carbonated drinks. And they sign agreement with this unit so forth because it helps in delivery supplies. But then you have a national policy that is trying to regulate food advertising, is trying to regulate sugary drinks, then it starts the conflict because these private companies, as I'm saying, they have been engaging with some parts of the Ministry of Health that then within the Ministry of Health, that's when the conflict starts, when they try to have the national regulation of food advertising. So,
thank you very much. Thank you very much, Walter. I think it's quite clear. We have issues of powers indeed, and we have issues of the role of the Ministry of Health and the separation of powers with regard to resources and provision of services. We have also very often issues of coherence within governments and from time to time within the Ministry of Health itself, and maybe the rethinking of the role of the Ministry of Health for the SDGs is critically important. Thank you very much. Before giving the floor to Bob and Sara for answers, I would like to take our second discussant, Mr. Eddie Premdas Pinto, who is the Director of the Research and Advocacy Health Governance and Accountability in the Center for Health and Social Justice in New Delhi. And I would like Eddie to provide us with his views on this presentation with regard to the situation that he is currently facing in India and probably what he is recommending for his own country. Eddie, you have the floor.
Thank you for the wonderful presentation. I'm sorry my internet connection was weak. I have logged into the phone. So I think I continue with Walter Flores's comments, and I agree with him that it is a question of power. And the paper has laid down very clearly and vast canvas of governance issues and the importance of governance. I agree with the paper saying that the governance has to be strengthened. And that and one of the key factors that I picked up from the paper is the centrality of institutionalization and putting mechanisms in place for governance. But however, I have 2-3 points to make from the Indian context. This number one, when with the health sector, it is not one homogeneous entity. Our national health accounts has just come out with all the data, and we have a scenario where 75% health care is being is now accessed or financed in the private sector, and about 25% only remains in the public health sector. So for us, when it's a health sector governance, it has to be the public healthcare sector and the private healthcare sector. These are two different things. And we have a scenario where now the private healthcare sector is leading and is in the driver's seat, and it resists any form of governance. We have just had a campaign in one of the states called Karnataka for amendments to bring price regulation, to bring ethics protocols, and to bring patients' rights charter as part of one existing legislation which is weak. But what happened is entire private sector brought the government down to knees. It shut down hospitals, including charitable institutions, for several days. There were protests by the government doctors. So basically, I think that has to be factored in very, very clearly when we say governance. The second one is the state invests much in military, a lot of things in policing, all that thing. It does not mean that state does not know that governance is important, and governance means institutionalization. So what is the politics behind disinvesting in health and making the health system very weak? It is not an uninformed institution, as if the public health researchers have to tell the government with evidence. It is a political decision. So we have to understand the politics behind weakening governance, especially in the low and middle income countries, and why our GDP investment in India is only at 1.2%, whereas it should be minimum 2.5 to 3%. So basically, my two important points are that the politics of governance and politics of making these decisions and weakening governance is an important factor that we need to factor in and we need to understand. And we have to have a factor or deal separately when it's a health sector, demarcate private healthcare sector vis-a-vis the public healthcare sector. Public healthcare sector is weak, and the private healthcare sector resists any form of governance and regulation. And regulation is the only forms of governance to have rational practice of medicine, ethical care, respect for patient rights. Unless that happens, only speaking governance in generic terms is not going to help us even in building these mechanisms and institutionalization of health governance in terms of people accessing it with affordability and with access and all the human rights elements that you have spoken about. Thank you very much.
Thank you very much, Eddie. And again, yes, the issue of power is the issue of private sector, and from time to time the difficulties that the government has to regulate properly the private sector. It would be interesting to analyze also these regulation of the private sector in different contexts. I mean, when we have weak health systems or when we have strong health systems. I thank you for your comments. I would like immediately to ask Cedar Pion from the Liverpool School of Tropical Medicine to provide her insight. And I would like also to invite the other participants to raise their hands if they would like to intervene afterwards. Cedar, you have the floor. Thank you.
Yes, good afternoon. This is Sara from LSTM, Liverpool School of Tropical Medicine. Thank you for giving me time to ask. And I have only 3 questions to the panelists. First is that, you mentioned about this governance, but in explaining, for instance, the examples that you've given, it's on the accountability. So, governance composed of other principles. I think other people have already stated about transparency, participation, rule of law, and those things. So I think we shouldn't just focus on accountability. And I think also one of the discussants also highlighted about this new report of World Development Report. I think that comes out because, they acknowledge that just focusing on accountability, especially on the principal agent approach, is focused more on individual, while governance composed of the collective actions that, individual actions will not solve. So if to give an example, if you have control of corruption measures, so individual actions will not solve. If individual has want to fight against control of corruption, but as a collectively, if you don't solve that, it will not solve the problem. So the other thing that I want to comment is that I think it's framework are still important because we need to get the right framework, especially to guide us and to also to highlight and buy in this political will from the government. And also Sara commented that, from the systematic reviews, the current findings, especially for the higher level, are mixed results. So I think we need to have more research on having, more, more research that are of positive outputs of governance on health, because especially, the relationship between governance and how it impacts on health, I think it's quite difficult to in a study design. So these are my 3 points. Thank you.
Thank you very much, Cedar. And I think it's also a very very important, and I agree with you that certainly we have some aspects of governance that are well understood, and maybe some others that are less, and we need probably to refocus on several key aspects of governance. But I think also it was quite well explained in the paper of Bob, Sara, and Agnès. And I would like to give the floor back to Bob and Sara to get their feedback on these 3 first set of comments. Sara, Bob, who wants to answer first? Sara, maybe, ladies first.
Okay, thank you very much, Gerald. Can you hear me okay?
Yeah, very well.
Good. So thank you to all 3 of the panelists for some very interesting comments there, which by and large I agree with. I think that underscoring the importance of power in governance is important, and I hope my comments sort of reflected that I agree that power is critical. Whether it's the only thing that has been dampening discussions about governance, I'm not entirely clear on. I do think that it's critically important in terms of how our conversations and our ability to strengthen governance unfold in different countries. But I think it points to us being more savvy about understanding power in different contexts. And I think, we're beginning to see some of that kind of research, but also power is quite difficult to assess, to measure. It has different forms that it takes in different contexts. So I do think that, as an example, we're currently trying to do some relatively small-scale research around community scorecards through the Future Health Systems program. And it's taken us an awful long while to get to the point where we even begin to feel vaguely ready to intervene, because it's a complicated environment that we're intervening in. And one of the things that we think is important is to understand the existing power relationships within the context. So I think that we need to have more tools to document and to understand power in a way that is good enough to enable us to move forward. I mean, the second point that I think I heard from several of the panelists was around the strength of particular groups, particularly around professional associations and the private sector. And I agree. I mean, I think particularly in the Indian context, you see the Medical Council of India, for example, as well as the private sector, being hugely influential around some of the policy decisions and some of the governance issues in that particular context, and the same is true in other countries that I work in. But I think that firstly, that does vary somewhat by context, and I also think it's very path dependent. So it seems to me that, you know, we make decisions now that will affect the influence and power that those kind of associations and stakeholders wield 10 years down the line. And I'm not always sure that we think enough about the long-term consequences of the interventions that we're making. So, you know, it may seem like a good idea to encourage greater private sector participation, but then over a period of time, we recognize the full implications of that and the power that has sort of imbued amongst private sector stakeholders, and that can be a double-edged sword. So I think thinking more about the long-term consequences of how we intervene in health systems and how that affects power relations down the line is important. And then thirdly, there were a couple of comments around governance as a generic term, and maybe we focus too much on accountability. And I guess I don't see governance as a sort of big homogeneous blob. I think it has a lot of varied purposes, varied instruments that can be used. And I do think that this is one of the challenges of working well on governance, on the governance agenda, is sort of knowing which governance tools and mechanisms to employ in different contexts. And just sort of reflecting on Figa's final comments about the importance of frameworks, I think I would tend to agree. I mean, I feel that frameworks are important if they allow us to identify how best to approach a particular governance challenge. And I do think that we need frameworks to assist with that, recognizing that, you know, politics is important, politics and power is important across this whole agenda, but we still need to have good conceptual tools to analyze particular contexts and to figure out how best to intervene or approach them. And it's certainly not a sort of one size fits all kind of situation. So I think that, as always, this is a complicated environment, but in some respects, we need to think about simplifying our messages so that we can speak to a broader audience. And, you know, I'm thinking about the importance of simplification for when you've got that 3 or 4 minute window with a health secretary, and you need to be able to say, well, this is why this is an important issue, and this is why we might need to think about addressing it. But I think at the same time, we need a more sophisticated understanding to support that, so that we can say, well, it's not the same tool in every context. We may use different approaches according to what we're trying to do, how we understand the existing context and the power relations embedded within it. Thank you.
Very much, Sara. This is very very important to remind also that one size doesn't fit all, and that we may need to use different tools or to act on different aspects of systems depending upon the situation that prevails in the country. And I think that we have received some tweets also about that, but we can discuss about that later on. Bob, do you have some some reactions to the three discussants' comments?
Yes, thank you very much, and great comments. I'll just make a few reactions, building on what Sara said. First of all, I mean, obviously, with the paper, I realise we are being provocative deliberately, this process of trying to simplify our arguments, just building on what Sara said, I think we have to realise we are talking to different audiences, and sometimes we do need more simple messages to get our point across. I totally take the point that we must all be thinking and working politically. I mean, that's almost like a core skill set for all of us working in international public health, and we must be aware of the power and the politics and how we engage in that. So I totally get that point, but I do think there are different audiences, and so some audiences you want sophisticated arguments and complex research and rights-based arguments, and in some other audiences you want simple messages that gets the point across and gets our change, the changes that we want to happen. And I personally, I think, have seen a big step forward when it comes to financing health, simply because some of the functions around financing, some of the processes were just simplified. And whereas 15 years ago we could not have discussions with policymakers around financing for health, and now we can, because we've got some simple tools, simple arguments. We don't always win those arguments, but we have some simple ways of putting them across. I agree with most of the other points that were made, I think, about the conflicts of interest in the Ministry of Health. I think that's very well made points. On India, I know it's a very, very difficult situation. And I suppose when it comes to the governance, I mean, the private sector there, yes, all powerful, and it's a very dangerous situation. And I suppose we had to have arguments to show it's in everyone's interest, both the government, the public, the citizens, and the private sector, to have good governance and good regulation. I mean, a good private sector should actually want effective regulation to keep the good, effective institutions in place and delivering what they should be. And I think that's the sort of how we get to that discussion in India. I can't even begin to think, but I know it's a very difficult situation. I also think there needs to be other things going on in parallel, because I mean the little amount of public money that goes into health in India is an international scandal, and but maybe that's a whole different set of arguments that has to be brought into play around that. So I think I'll leave it at that, but thanks very much. I think that was a great set of comments.
Thank you very much. Thank you very much, Bob. Indeed, we have, I think, a lot of food for thoughts from this first set of discussion. And as you really pointed, the private sector regulation needs to be understood in terms of advantages also for the private sector. That is also one of the outcomes of the discussions we have here in WHO in Geneva around the regulation of the private sector. I would like now to open the floor for the public and those who have raised their hands. The first who has raised his hand is Matt Greenall. Are you online, Matt?
So, yeah, I'm interested in short route accountability, and Sara mentioned the Uganda experiment, which I haven't looked at for a long time. But there was this issue around resources being provided to the health facilities, if I remember correctly. And I think one thing we've seen in community-based monitoring is it often makes a lot of noise and points out issues, but if service providers or health facilities don't have the flexibility to adapt and to make changes, then it can all go wrong quite quickly. So people get frustrated because they've been filling it in scorecards or reporting and nothing much is changing. And I think that I'd just like to know what Bob and Sara think about this. But I get a sense that, especially in aid projects, we don't really construct them in a way that gives local actors, local service providers, much flexibility or ability to adapt. So if they're constrained by very tight outcomes and results-based financing measures, then it can become quite difficult for them to respond to that local feedback. So I just wondered what your reactions are to that, and if there's something more we can do to provide sort of the resources and to empower and enable providers to actually do something with community feedback.
Thank you. Thank you very much, Matt. Clear question. I will take 2 or 3 more questions, and then I will come back to Sara and Bob. The second I have on my list is Sara. Sara Van Bell, do you have a question for us, Sara?
Yes. I wanted to tap into the discussion and the remarks of the panel. So I think obviously there's a difference in terms of what you would have as an advocacy tool and what you would have as a sort of conceptual framework. I think we really need to distinguish these. And I was wondering for I think I'm convinced that the health secretary, having worked in politics as a first job, is definitely understanding of the power of different coalitions and collusions between, for example, professional associations and ministerial departments. Maybe the message is far too complicated, so we need advocacy. And on the other hand, I think I would bring in the framework that idea of if emergent local collective action, like the previous person who commented said, like the adaptation and the things that come up from the bottom up. And is there a way to much more focus on the coalitions and networks and relationships in the framework? I haven't read the paper recently, so this was just a remark.
Thank you very much, Sara. Question well noted. I would like now to have Dr. Ashok Pudel Sharma. Dr. Ashok Pudel Sharma, are you with us? Are you on the phone?
Yes, Gerard. I would like to raise not to raise a question, but one comment in relation to the overall governance is that the working in the low-income countries, like the human resource HRH, health human resource capacity related to the leadership on the governance. I see that is one of the key factor in terms of really whatever the framework or any guidelines or tools be available, how we can really improve that component where in most of the health systems, still the medical doctors are still being recruited as a part of the governance. And the second thing I would like to raise is that the accountability, related to the accountability, like in most of the countries here in Asia Pacific, like in Myanmar, still we see like that the accountability measures are still not being less, but we are still talking about the community voices to improve it, but the type of accountability from the perspectives of the experienced people go, but the knowledge about the accountability itself, what are the voices to be raised to the health system from the communities is still an issue which I see. Thank you.
Thank you very much, Ashok. So Bob and Sara, so we had 3 questions related to accountability, to coalitions and networks, regulations, and also certainly the voice and participation. Do you can you please provide some elements of answers?
I agree with Sara. It'd be good to hear from the others to some of these points. They're all very good points. I mean, I'll just respond maybe on the first one, the point that Matt raised about the need for the community voice needs to be linked to the flexibility of response. And I think what I've seen and we're seeing written and also seen in practice is that you need to design it or come at it together. You can't have one without the other. You have to have a willing sort of set of providers who want to change, as well as actually having a more transparency around community and data and things. And that's ultimately how you should go. How you get that point of joint design and in designing the future is tricky, but I think that's the way it should go. And on the last point about workforce, in resource-poor settings, the problems of workforce and very, very difficult. And how do you get best use of workforce and resource force settings is a big question. But I think I agree with Sara. I think it'd be good to hear from the others on their views.
Thank you, Bob. So I will come back to you, Sara, if you have some thoughts on the issues of accountability and coalitions and networks.
Yeah, actually, I had wanted to respond first, if I may, to Matt's point. I think you're absolutely right, Matt, that this issue of empowering healthcare providers is as important as giving voice to the communities often. And I think that's why Jonathan Fox talks about the voice and the teeth being, you know, the power that goes along on the provider side. And I think that without that, in many contexts, we don't give decision space to those providers, but also conceivably concrete resources in terms of, you know, additional funding or whatever. And then there may be unforeseen effects and potentially negative effects from some of these interventions. And actually, there was a question in the chat from Sara Dalgleish about the risks to this kind of work. And I think that, you know, the potential risks include potentially burnout and disillusion amongst health workers who are working under difficult circumstances and maybe having additional pressures upon them to be accountable. And also conceivably retribution against community members is another risk, which I think in some of these situations, if we don't understand the sort of the politics and the power relations of the context that we're intervening in. So that's one of the reasons why I was sort of arguing that even where we have evidence that these types of interventions have the potential to be effective, we really need to track what's going on and understand both positive and negative effects. In terms of Sarah Van Bell's comments around the importance of understanding partnerships and coalitions, I agree entirely, Sarah. I mean, I think that the commentary sort of laid out the bare bones of a simple framework, but I don't think that any of us are saying this is the only framework that could be used or is relevant to address governance. And I recognize that it doesn't put a strong space for partnerships and coalitions. And yet I think increasingly, if you look at the governance literature, it suggests that effective governance is often networked governance. It means getting together different stakeholders who hold different types of resources, whether that may be information as a resource, financial resources, or conceivably just sort of legitimacy, having the resource of being perceived as the legitimate stakeholder to take action upon a particular issue. But frequently we need different stakeholders to come together so that we can join together those different types of resources in order to, or powers, if you will, in order to address a challenge in the environment. I do, in the governance class that I teach, we do an exercise which is looking at the challenges of pushing substandard, drugs. And essentially, the exercise is designed to get the students to recognize that for an issue such as this, where there is often weak regulatory authorities in low and middle income countries, the most effective way to address that kind of problem is really to build partnerships between regulatory authorities, citizens groups, as well as the providers themselves to try and address it. So I think the issue of networks and partnerships and coalitions is important, but we probably need to understand more the distinctions between those different types of groupings. Thank you, Gerard.
Thank you very much. Thank you very much, Sara. It's very clear the importance of coalitions and dialogue again. I would like to ask Nadej now, who has raised her hand, if she wants to ask her question now. Nadej? Nadej, Ade?
Can you hear me?
Good. Very well. Please go ahead.
Okay. So I was talking about this tension between the public sector and the private sector in terms of governance. And my question is, with this notion about the changing role of the Ministry of Health, how do we actually make sure that we're actually strengthening the public sector and so the Ministry of Health within this context of wanting to achieve universal health coverage, rather than actually weakening its power or its authority in favor of the private sector? So that's really my question.
Very interesting question, Nadej. We will answer to you, or try to answer to you just after. I would like also to ask Sylvia Vrietendorp, if you are with us, Sylvia, do you have a question for us?
Yes. I was thinking about levers, points of leverage, and combining that with simplification. And my experience has been with the COGES in Côte d'Ivoire, which is a local facility governing body. And I was at an event where the préfet, which is the local administrator, and the hospital directors and the women's organizations representatives who are all sitting on these committees were together. And the original intent was to do PowerPoints. These are illiterate market women, and I just realized that the messages were way too complicated. So the levers to me is helping people to talk across traditional boundaries, whether those are professional boundaries or societal hierarchy boundaries. And so that was one leverage point. And the other one is that the women tended to be quite angry about not having been heard previously, and they can't really speak out in the presence of these very high-level, mostly men, societal high-level men. And so their tendency was to just be the victim. We are poor, we don't have anything, why don't people come to rescue us? So there's a leverage point there about helping the women to recognize that they do have something to contribute and be agent rather than victim. So the key part is helping people to talk across traditional boundaries and outside their usual professional field. Thank you.
Thank you very much, Sylvia. Very, very interesting comments and inputs. So, Nadej, your question was about the tension public-private and the role of the Ministry of Health and versus the private sector. Sylvia, it's about talk across traditional boundaries. In addition, we have received two questions from Twitter. One that is about governance in fragile states, and what do we do when the government does not exist or is clearly weak? And the second question from Twitter is about the issues of governance in authoritarian regimes. Do we have solutions in such cases? So very provocative questions also on the Twitter. Sara, Bob, Tidar, Eddie. Walter is not with us anymore. I will give further floor to Tidar to see if you would have elements of answers to these four sets of questions. Then I will ask Eddie, then Bob, and then Sara. So Tidar, you have the floor.
Yes, thank you. So yeah, these are very interesting questions. So my first questions for Nadej is this, the questions on the public and private, especially, I think you asked a very important question, especially in that health system where governance is weak in low and middle income countries, where the private sector plays a very significant role. And I think I think the best is the role that MOA should play should be that they should have an independent body, and they shouldn't have the conflicts of interest. I mean, because there is this, especially regulating and enforcing the rules in private sectors in systems where governance is weak are not in place. So the weak enforcement, the regulations, they need to be strengthened, and they should have a separate independent professional bodies to regulate private sectors also. So that is, I think it's MOA should play a very critical role, and that is very important. And the other thing regarding with this governance in fragile state, where government is weak, and I think for that I will go to this Fryatt Abimbola's multi-level framework, which is based on this Elena Ostrom's, this theory of common pool resources. And I think we can learn a lot from that, especially in settings where where government undergoverned, where people, the individual, and the group of collective actions can come in place. So I think we can learn from that, especially governance in fragile state or where the government is weak. The other questions on this governance in authoritarian regime is a bit tricky. But the thing is, if we can make those authoritarian regimes to have their political interest. And I think if we go back to the latest World Development Report of 2017, and it highlights a lot on the role of elites. And I'm not equating elite with the authoritarian regime, but somehow elites play a significant role in authoritarian regimes. So I think we can learn a lot from this World Development Report the recent one. And the last point on this local facilitating governing body on crossing the traditional boundaries. And this is very interesting, and also to make a voice for those underprivileged groups. But I think it should go together with the top-down power, not only the bottom-up, so that we can have all the complementary and synergistic effect together. Thank you.
Yeah, I agree with you, particularly on the issues and these tricky questions about authoritarian regimes. And certainly we should have another set of discussions around these at a later stage. Bob?
Yes, thanks. Just a couple of, great points being raised. On the Ministry of Health, I think a very good points made in that last response about some of the solutions. I think, Gerard, you're probably in a better position than anyone, but there is clearly a big shift in expectations of ministries of health and of governments, where they actually should be much more focused on equity and ensuring that everybody gets what they need, rather than just around the public service. And because how countries do that varies from country to country. But I think we do need to make sure ministries of health are accountable for the health of everybody, and that should be a sort of the driving goal. And I think WHO actually has a key role to play in that. I think the point about working across boundaries, I think that was a tremendous point, the example from Côte d'Ivoire, and I think there may be some good lessons there about what can be done practically, because many health providers and policymakers aren't aware of these problems on the ground, and how do we build in skills and understanding so those that want to change and want to respond and want to listen can do that, because I think many do not have the skills or the experience to sort of speak across boundaries to local people. So I think there needs to be change on both sides there. And then the last point about working in fragile states, from my limited experience, I think it's a matter of what works. If there's no government, there has to be a non-government role, and a very strong one, perhaps supported by international support, and that is possible in some situations. Of course, it's very difficult, but I think you do need governance, and whether that's done by a government or by a non-government role, but agency, I think you still need the basic principles of governance if people are going to be protected and secured and given health care. I'll leave it at that, Gerard.
Thank you, excellent. Sara?
Thank you very much. So both some excellent questions, and fortunately the other panelists have done a good job in providing some excellent answers. Maybe I can add just a few points. I thought Nadesh's question is a really important one. I feel often that Ministry of Health could sometimes do with kind of retooling. I think that so many of them have been structured and set up to really provide healthcare services, and so they are less they have less capacity and their organizational structures are less conducive to different roles, which I think are increasingly important, including working with the private sector, developing strategic plans that are responsive to rapidly changing environments. So I think some of these kind of intelligence functions within ministries of health, and also their ability to negotiate with private healthcare providers or private healthcare associations are critical, and often ministries don't have those kind of capacities well established, and maybe there's more we could do to help with that. I thought Sylvia's insights from Côte d'Ivoire were really interesting, and I've seen somewhat similar things play out in different contexts. In one of the projects I was working on, we actually tried to use photo voice to enable women to present their concerns in a way that was both visual, but also I think that the photographs gave them a prop for their conversation with senior policymakers. But I think that one of the issues there is that those kind of conversations across professional boundaries can be very uncomfortable for some people. And so I think we need to learn more about how can we, what kind of facilitation supports those exchanges, and how can we conduct those exchanges in a way that make them sustainable, mean that people are willing to re-engage and come back. Because if they feel too uncomfortable and feel that their power has been too threatened, or that they feel that they've been too humbled by an experience, and then they won't re-engage. So I think there's still more that we can learn about effective facilitation of that kind of exchange. And then those super big questions on Twitter about how do we do this in weak and fragile states? How do we do this in authoritarian regimes? Again, I think the other speakers have already posed some good suggestions. In terms of conflict-affected and fragile states, one of the things that I wanted to highlight was really this notion again of path dependence. I think that often post-conflict, there's a feeling that we need to get services out as quickly as possible, and that in itself is a way to help build trust in a government, potentially a new government. And yet there's perhaps insufficient consideration of how are we through that process building capacities within government. For example, often you see services being contracted out. What's government's role in that? How can you capacitate government to manage those kind of relationships going forward? So I think even from the word go, we need to be thinking about a long-term strategy for building governance capacity in those type of post-conflict and fragile settings. The authoritarian regimes are a lot harder. Thank you.
Thank you very much. Thank you very much, Sara. I think that these are certainly part of the conclusions of this webinar. It's a question that we have raised also within these health systems governance collaborative. It's about the changing role of the Ministry of Health. It's critically important. Your paper was quite clear that we need to move away from theory and be much closer to the practice. So changing the role of the Minister of Health, of course, we all know that it's absolutely needed. Being really in the steering position, being the steward of the sector, of the private and the public, is really needed for universal health coverage. This is something that we know needs to be achieved, and the sooner the better for achieving the universal health coverage goals. But how do we do in practice? And it was certainly raised by many participants. How do we do that? And thanks a lot, Sylvia, for providing concrete inputs with your example from Ivory Coast. I think we have a lot of actions to do. We have a lot of things to do in practice on voice and on participation of the different stakeholders into the governance in practice in countries. We have a lot of things to do with regard to information and transparency, making sure that we are evidence-based, but that also the information is shared with the population and the service providers, public or private. We need to make sure that we have the needed institutions to do the work, and we need to make sure that laws and regulations are there also. So certainly a lot of work to do, lot of other webinars to take place. An important question that came from Twitter was about authoritarian regimes, and maybe we can plan something on this critically important question. This it's exactly 4:30, so it's time now to close. There will be maybe I can ask for comments from our two colleagues from Shapes. Do you have a last comment for us?
Hi, this is Carrie joining you from Bangalore. Steph is in Australia, and so it's about 1 a.m. or 1:30 a.m. for her, so she's not online anymore, but we're both really pleased to have been involved in organizing this webinar, and we wanted to thank the panelists and the discussants as well. And we hope that in Shapes we can build a lot more momentum around working on governance, and that's a sub-area within Shapes that we don't yet have a team. So definitely something to think about, and those who are interested, please do get in touch and join our group.
I would like to thank you, Kerry, and to thank, of course, Stephanie, who is not with us from Shapes. Would like to thank a lot Bob and Sara for the fantastic work and fantastic presentations. To thank Jennifer Leopold. To thank again Benjamin Rufi, Mariam Bigdeli, and Gurli Van Heteren. To thank our discussants, Walter, Theodore, and Eddie. To thank the more than 70 participants to this webinar. Thanks a lot to all. And last but not least, to thank Dragana Ivanovic, who has helped us with the technology that is, for me, not easy. Thanks a lot to all, and hope we can have you all on board for the third webinar that will take place in January. You'll be informed on due time. Thanks to all, and have a fantastic day, afternoon or morning, depending on where you are. Thank you very much. Bye-bye.